4 medical checkups I'd never get after 65. A doctor explains why. The ingrained habit of diligently following medical advice, particularly when it comes to routine preventive screenings, is deeply embedded in our collective consciousness, a practice often undertaken without a second thought or a probing question. You likely attend these appointments, perhaps annually, trusting implicitly in the system and the recommendations of your healthcare provider, a trust that is both fundamental to patient care and, paradoxically, at times, a pathway to unintended harm. For after dedicating over 2 decades to the intricate field of internal medicine and working intimately with a vast array of older adults, my perspective on these seemingly innocuous checkups has undergone a profound transformation, compelling me to share a truth that many in my profession shy away from articulating explicitly. Some of the diagnostic tests routinely ordered for individuals once they surpass the age of 65 are, with a disquieting frequency, more likely to precipitate adverse outcomes and diminish one's quality of life than to confer any genuine, lasting health benefit. A stark reality that often remains unspoken in the confines of a doctor's office. My name is Dr. Abraham Khan, and throughout my entire career, my singular focus has been on guiding patients navigating the complex and often bewildering landscape of medical decisions post-age 60, equipping them with the wisdom to discern precisely when decisive action is warranted and, crucially, when it is far more prudent to simply observe and allow the body to be, a nuanced understanding that is conspicuously absent from much of the conventional discourse surrounding preventive care. Today, I feel an urgent professional and ethical obligation to impart knowledge that runs counter to virtually every piece of advice and every well-intentioned directive you have likely absorbed concerning health maintenance and early disease detection, specifically highlighting 4 routine medical checkups that, based on extensive clinical experience and rigorous scientific evidence, I personally would unequivocally decline after reaching the age of 65. This isn't born of a cynicism towards medicine itself. On the contrary, I am a staunch believer in the power of modern medical science to heal and to save lives. My reservations stem from witnessing, time and again, the often unforeseen and profoundly negative consequences that unfold when these particular tests uncover an abnormality within the body of a 70 or 75-year-old individual. Consequences that diverge significantly from the positive outcomes one might instinctively anticipate. Before we delve into the specifics of each of these 4 potentially perilous screenings, it is absolutely imperative that you grasp one foundational concept, a singular idea that possesses the power to fundamentally reshape and inform every single medical conversation and decision you engage in from this moment forward. This critical principle is known as the cascade effect, a phenomenon I have observed with alarming regularity and which dictates a predictable, often detrimental sequence of events. The cascade typically initiates innocently enough. You present for a routine screening test, perhaps feeling perfectly well. The test, designed to be highly sensitive, identifies some anomalous finding, a something that, on initial review, appears concerning or deviates from a statistically averaged norm. This finding, while potentially benign, necessitates further investigation, prompting your doctor to order yet another, more invasive or more specialized test for a closer, more definitive look. This subsequent test might reveal something subtly different, perhaps confirming a minor anomaly, but adding another layer of complexity. At this juncture, the system often dictates a referral to a specialist, an expert tasked with deciphering these increasingly intricate findings. The specialist, operating within a framework that prioritizes diagnostic certainty and often proactive intervention, frequently recommends a small procedure, ostensibly just to be sure or to definitively rule out something serious. However, even minor procedures carry inherent risks, and it is at this stage that a complication can regrettably arise. This complication, in turn, necessitates its own course of treatment, perhaps involving hospitalization, further medication, or additional procedures. The cumulative effect of this chain reaction is stark and sobering. 6 months after walking into a clinic feeling entirely healthy and functional, an individual who was previously asymptomatic now finds themselves managing 3 entirely new medical diagnoses, adhering to a regimen of 2 new medications, and, heartbreakingly, exhibiting a significantly reduced level of overall function compared to their initial healthy state. I have observed this precise, unfortunate sequence of events unfold more times than I can possibly enumerate throughout my extensive career. This isn't a commentary on the carelessness or incompetence of medical professionals. Rather, it underscores a fundamental characteristic of modern medicine itself, which is intrinsically designed to identify and categorize anomalies. Once an abnormality or finding is detected, the entire intricate structure of the medical system is inherently built to respond to it, to pursue it, and to intervene. The core of the problem, however, lies in the crucial distinction that not every deviation from the statistical norm, not every finding within an aging body, genuinely necessitates or benefits from an immediate, aggressive medical response. Furthermore, there is a second, equally vital aspect that every patient, especially those over 65, must internalize. The vast majority of established medical guidelines, those benchmarks that inform doctors' decisions regarding screenings and treatments, were meticulously developed and validated using extensive research primarily conducted on younger adult populations. These guidelines were then, somewhat expediently and often without robust age-specific evidentiary support, simply extended upwards to encompass older patient demographics. The delicate and critical calculation of risks versus benefits, which might render a particular medical test entirely sensible and advantageous for a 50-year-old, can appear dramatically and alarmingly different when applied to a 70-year-old. This crucial recalculation, this nuanced reevaluation of the utility and safety of a screening in the context of advanced age, almost invariably fails to occur as a transparent, shared decision-making process within the examination room. Let me illustrate the profound impact of this cascade effect and the misapplication of guidelines through the poignant story of a patient I will refer to as Theodora. Theodora was a vibrant 73-year-old, a former teacher who had enjoyed a long, fulfilling career and remained remarkably active, fiercely independent, and mentally astute. She presented for her annual physical examination feeling entirely well without a single complaint. Her diligent physician, adhering meticulously to what are considered standard medical guidelines, ordered a comprehensive suite of routine preventive screenings. Among these, one specific test, which I will name shortly, yielded an abnormal result. What subsequently unfolded over the following 9 months was a textbook example of a medical cascade, a sequence of events that no one had planned for, and certainly no one had predicted, leading to a tragic deterioration in Theodora's previously robust health. This initial abnormal finding triggered 3 additional diagnostic tests, followed by 2 separate referrals to specialists, and ultimately, one seemingly minor procedure, which unfortunately resulted in a minor bleed. This bleed, while not immediately life-threatening, required ongoing medical monitoring, which in turn necessitated the prescription of new medication. One of these medications, a drug introduced to manage a complication that stemmed from a test for an asymptomatic finding, caused debilitating dizziness. This side effect proved devastating for Theodora. A woman who had been completely self-sufficient and independent experienced a fall in her own bathroom, resulting in a fractured hip. While she eventually recovered from the acute injury, Theodora was never able to regain her previous level of independence and function. The original finding from that first routine test, the anomaly that set this entire cascade in motion, was ultimately, after months of investigation and intervention, determined to be clinically insignificant, a benign deviation that was never going to pose a threat to her health. Tragically, it was the very process of investigating this harmless finding that caused her profound and lasting harm. We will revisit Theodora's compelling case because the poignant question she posed to me during her rehabilitation is one that I believe every single older adult across this nation unequivocally deserves to ask their doctor before consenting to any screening or diagnostic procedure. Now, let's turn our attention to the specific checkups that warrant extreme caution after the age of 65. Checkup number 1. Routine full-body CT scans. The concept of whole-body CT scanning has been aggressively marketed and promoted to health-conscious adults as the ultimate paradigm of preventive health, promising an unparalleled, comprehensive internal assessment. The allure is undeniable. You undergo a complete scan from the neck down to the pelvis. The sophisticated machine meticulously examines every internal organ and structure, and you walk away with the reassuring, or potentially alarming, knowledge of precisely what is occurring within your body. On the surface, this appears to be the most intelligent and proactive step one could possibly take for their long-term health. Herein lies the fundamental and often overlooked problem. When an entire human body, particularly one that has accumulated decades of living, is subjected to a comprehensive scan at age 65 or older, it is virtually guaranteed that the scan will identify something. This ubiquitous finding is not necessarily indicative of a nascent disease process or an impending health crisis. Rather, it reflects the natural, expected accumulation of incidental physiological changes that are simply part of the normal aging process. These incidental findings might include small, often calcified nodules in the lungs that have existed harmlessly for decades without ever causing symptoms or progressing into anything clinically significant. They could also involve tiny, benign cysts on the liver or kidneys, entirely innocuous structural variations. Frequently, the scans detect minor abnormalities in the spinal column, which are simply normal manifestations of age-related structural wear and tear, not indicative of pathology. The medical term for these ubiquitous findings is incidentalomas, findings discovered entirely incidentally during a scan for an unrelated purpose, findings that were never causing symptoms and, crucially, were never destined to cause any future problems. However, here is where the cascade begins its insidious progression. When the radiology report containing these incidental findings lands on your doctor's desk, they are both legally and professionally obligated to investigate them further. The system, once again, demands a response. A lung nodule, even a tiny, seemingly benign one, will almost inevitably trigger a recommendation for follow-up CT scans, often scheduled every 6 months for a period of 2 years or more. This repetitive scanning exposes the patient to a significant cumulative dose of radiation, which is particularly concerning for older bodies whose cellular repair mechanisms, responsible for rectifying DNA damage caused by radiation exposure, are demonstrably less efficient than they were at age 40. In some instances, these follow-up scans might show subtle, often insignificant changes in the size or appearance of a nodule, which then triggers a recommendation for a biopsy. Biopsies of lung tissue, especially in older adults, are not without their own set of serious risks, including bleeding and the potential for lung collapse, pneumothorax. A seminal study published in JAMA Internal Medicine unequivocally demonstrated that whole-body CT screening led to further diagnostic testing, staggering 37% of participants. Yet the vast majority of these findings were ultimately determined to be clinically unimportant or benign. Meanwhile, the downstream testing, the cascade of investigations, caused genuine complications and distress in real people. To put the radiation exposure into perspective, the radiation emitted from a single whole-body CT scan is roughly equivalent to approximately 3 years of natural background radiation. When you factor in the reduced capacity of cells at age 65 to efficiently repair radiation-induced DNA damage, repeated scanning compounds this risk significantly, potentially increasing the long-term risk of secondary malignancies. Therefore, the essential question that must be posed before agreeing to any CT scan, particularly a whole-body screening, is: Do I currently have specific symptoms or medical conditions that this scan is precisely intended to investigate and diagnose? If the honest answer to that critical question is no, then it is imperative to pause and reflect with extreme caution before consenting to such a procedure. Moving on to checkup number 2, routine bone density scanning, specifically after the age of 80. DEXA, dual energy X-ray absorptiometry scanning, is a highly effective and valuable tool for measuring bone mineral density, primarily employed to screen for osteoporosis. For women in their late 50s and 60s, identifying low bone density at this stage is genuinely beneficial. It creates a crucial window of opportunity to intervene with appropriate medication and targeted lifestyle modifications, such as weight-bearing exercises and nutritional adjustments, that can meaningfully reduce the risk of debilitating fractures over the ensuing decade. However, once an individual has passed the threshold of 80 years of age, the underlying medical calculus changes profoundly and significantly alters the risk-benefit profile of routine DEXA scanning. Here is what frequently transpires when a routine DEXA scan reveals a diagnosis of osteoporosis in an 80-year-old or 85-year-old patient. The established standard clinical response is to initiate treatment with bisphosphonate medications, a class of drugs that includes agents such as alendronate or zoledronic acid. While these medications are undeniably effective at increasing bone density readings on subsequent scans and are vital for younger, at-risk populations, comprehensive research published in highly respected journals like the British Medical Journal and the New England Journal of Medicine has raised serious, evidence-based concerns regarding the widespread and long-term use of these medications in very elderly patients. The first, and perhaps most alarming concern, is the development of a rare but extremely serious condition known as atypical femur fracture. With prolonged use of bisphosphonate medications, the structure of the bone, particularly the thigh bone, femur, can paradoxically become brittle in highly specific ways, leading to spontaneous or low-trauma fractures that occur with minimal force. These atypical fractures are excruciatingly painful and notoriously difficult to repair effectively in elderly patients, often necessitating complex surgeries and leading to prolonged recovery periods and significant reductions in mobility and independence. The second grave concern is osteonecrosis of the jaw, ONJ, a devastating condition where the jawbone begins to die, leading to exposed bone, infection, and severe pain. This condition is particularly associated with bisphosphonate use in older adults, especially those undergoing dental procedures, which can trigger its onset. The broader, overarching point that often gets lost in the focus on a single DEXA number is this. After the age of 80, the most effective and safest strategy for preventing the devastating consequences of a hip fracture is not primarily achieved by treating a numerical scan result with potent, risk-laden medication. Instead, the focus should shift emphatically towards directly and comprehensively addressing the underlying risk of falls. Evidence-based interventions such as structured fall prevention programs, targeted strength training regimens specifically designed to improve balance and coordination, thorough home safety modifications to eliminate hazards, and meticulous medication reviews to identify and adjust drugs that contribute to dizziness or cognitive impairment have all demonstrated strong, reproducible evidence for effectively reducing the incidence of actual fractures in this vulnerable population. Therefore, a DEXA scan that prompts immediate medication prescription without a concurrent, detailed fall prevention assessment and strategy is fundamentally misdirected. It is addressing a measurement rather than tackling the real, multifactorial problem of fall risk in the elderly. If a DEXA scan is proposed after the age of 80, the pivotal question to ask is, will the specific result of this scan genuinely alter my treatment plan in a way that goes beyond what a comprehensive fall prevention assessment would already recommend and implement? If you have journeyed this far through this crucial discussion, it is unequivocally clear that you are deeply invested in understanding and proactively managing your own health, a commendable attribute. Many viewers might consume content such as this, find it compelling, but then simply scroll away, neglecting to take the small, immediate step of subscribing. If this information truly resonates with you and feels genuinely important, I implore you to tap that subscribe button. It takes but a mere second of your time and ensures you remain connected to a channel dedicated to empowering you with honest, evidence-based medical insights. Otherwise, it is highly probable that you will forget this channel exists, inadvertently missing out on a wealth of valuable educational content yet to come. Now, let's explore checkup number 3, carotid artery ultrasound without symptoms. The carotid arteries are two critically important, large blood vessels situated on either side of your neck, serving as the primary conduits for oxygenated blood flow to the brain. Over the course of a lifetime, these arteries can develop fatty plaque deposits, a process known as atherosclerosis, which can progressively narrow the artery's lumen. This narrowing, or stenosis, combined with the potential for a piece of plaque to break off and travel to the brain, theoretically poses a risk of causing a stroke. Consequently, carotid ultrasound scanning is frequently ordered as a routine preventive measure in many clinics for older adults, with the explicit aim of identifying these plaque deposits and potential narrowing as a stroke prevention strategy. On the surface, this approach sounds entirely logical and sensible. Locate the potential problem, then fix it proactively before a devastating stroke can occur. This seemingly straightforward logic is undeniably appealing and aligns with our intuitive desire for early intervention. However, the robust body of scientific evidence does not fully support this appealing logic for asymptomatic individuals. Herein lies the critical issue. The established procedure typically utilized to treat significant carotid artery narrowing is called carotid endarterectomy. This is the major surgical operation that involves making an incision in the neck, opening the carotid artery, and meticulously removing the accumulated plaque. While effective in certain contexts, this surgery itself carries an inherent and non-negligible risk of causing a stroke either during the procedure or immediately in its aftermath. This is because the act of disturbing plaque within an artery so close to the brain is an intrinsically delicate, high-stakes, and risky intervention. In stark contrast, for patients who have already experienced symptoms suggestive of carotid disease, such as a minor stroke, ischemic stroke, or a transient ischemic attack, TIA, often referred to as a mini-stroke, carotid endarterectomy has clear and compelling evidence of significant benefit in preventing future, more severe strokes. However, for patients who are entirely asymptomatic, meaning they exhibit no symptoms whatsoever, multiple large-scale, rigorously designed studies, including the highly influential ACST, Asymptomatic Carotid Surgery Trial, and AKS, Asymptomatic Carotid Stenosis and Stroke, trials, have consistently found that for asymptomatic patients over the age of 70, the surgical risk of experiencing a stroke during or after the endarterectomy procedure is either equal to, or in some cases, actually exceeds the long-term stroke risk associated with simply doing nothing and managing the patient conservatively with optimal medical therapy alone. In essence, the test identifies a problem. That problem then becomes the target of an operation. And tragically, the operation itself causes precisely the catastrophic event it was intended to prevent. The guidelines issued by the prestigious American Heart Association are unequivocally clear on this matter. Routine carotid ultrasound screening in adults who do not exhibit any symptoms is explicitly not recommended as a standard practice due to the lack of evidence supporting its benefit over its risks in this specific population. Yet, despite these clear guidelines, it regrettably continues to be ordered regularly in many clinical settings. If your physician recommends a carotid ultrasound and you are entirely free of any symptoms of stroke or TIA, it is absolutely essential to ask directly and firmly, if this scan indeed finds narrowing, what is the precisely quantifiable stroke risk associated with undergoing the proposed surgery, compared to the equally quantifiable stroke risk of simply optimizing my blood pressure and cholesterol medications instead without surgical intervention. You are fully entitled to both of those crucial numbers, and your doctor should be prepared to provide them for an informed discussion. Finally, we arrive at checkup number 4, aggressive cardiac catheterization after a positive stress test, particularly in the absence of any symptoms. I have deliberately reserved this particular checkup for last because it carries the most serious and potentially devastating consequences for older adults. Indeed, among the 4 screenings discussed, this is the one that I firmly believe possesses the highest potential to inflict harm rather than to confer any genuine benefit in asymptomatic patients over the age of 65. Here is how this scenario typically unfolds. A patient over 65, perhaps feeling perfectly healthy, undergoes a routine cardiac stress test. Crucially, they experience no chest pain, no shortness of breath during physical activity, no fainting spells, and no other symptoms of any kind that would suggest underlying heart disease. Nevertheless, the stress test is ordered as a routine, quote, preventive measure. The stress test subsequently returns an abnormal reading, indicating some potential compromise in blood flow to the heart. Upon reviewing these results, the cardiologist, operating within a paradigm that often favors aggressive investigation of abnormalities, recommends cardiac catheterization. This is an invasive medical procedure where a thin, flexible tube, catheter, is carefully inserted into an artery, typically in the wrist or groin, and then skillfully threaded up into the coronary arteries that supply blood to the heart muscle. Once in position, a special dye, or contrast agent, is injected, allowing the blood vessels of the heart to be directly visualized and imaged, revealing any blockages or narrowing. Cardiac catheterization, while a cornerstone of diagnostic and interventional cardiology, is by no means a risk-free procedure, and it carries distinct and serious risks, especially for older patients whose bodies are more fragile and have reduced physiological reserves. These risks include significant bleeding at the catheter insertion site, potential arterial injury during the catheter's advancement, kidney damage from the contrast dye, a particularly serious concern in older patients who often have some degree of pre-existing reduced kidney function, and a small but very real risk of stroke during the procedure itself, which can be caused by tiny air bubbles or fragments of plaque being dislodged and traveling to the brain. However, the truly devastating finding, one that has fundamentally reshaped our understanding of managing stable heart disease, comes from 2 landmark studies, the COURAGE trial and the ischemia trial, both published in the prestigious New England Journal of Medicine. These trials unequivocally demonstrated that in patients with stable coronary artery disease, meaning blockages are present but not causing acute symptoms, and crucially, no significant cardiac symptoms, aggressive intervention through cardiac catheterization followed by stenting, inserting a small mesh tube to open the artery, or bypass surgery did not reduce the rate of future heart attack or death when compared to managing these same patients with optimal medical therapy alone. In simpler terms, medications such as statins, aspirin, and blood pressure drugs manage these patients just as effectively, achieving the same long-term outcomes, but with significantly fewer procedural risks and complications. This profound finding means that for an older adult who is completely free of any cardiac symptoms, a positive, but potentially false positive, stress test leading to an invasive cardiac catheterization and subsequent stenting may expose them to all the inherent procedural risks while delivering absolutely none of the additional protective benefit that the very same medications would have provided anyway, without the need for invasion. It is also important to recognize that stress tests inherently have a relatively high false positive rate in older adults, and notably, this rate is even higher in women, meaning an abnormal result does not always accurately reflect actual underlying disease. A positive result in an otherwise symptom-free patient often initiates a cascading chain of events that, according to the most robust scientific research, may not only be entirely unnecessary, but also carries significant potential for direct harm. Therefore, before agreeing to undergo cardiac catheterization based solely on an abnormal stress test and without any accompanying symptoms, it is absolutely paramount to ask your cardiologist directly, do I have any actual symptoms of heart disease, such as chest pain or shortness of breath? And if I do not, what does the definitive evidence from landmark trials show regarding the long-term outcomes for individuals like me who are managed solely with optimal medication compared to those who proceed with an invasive procedure? The response to this vital question should not be a curt referral slip, but rather a comprehensive, transparent, and unhurried conversation that thoroughly reviews the evidence and considers your individual preferences and circumstances. I promised earlier that we would return to Theodora after she embarked on her recovery journey. During one of our heartfelt conversations, she articulated a question that now resonates with me every single day, a query that embodies the core of this entire discussion. She looked at me and asked, "Doctor, if I had only known to ask one single question before that very first test, the one that started everything, what question should it have been?" I shared with her the answer, an answer that I believe is universally applicable and consistently empowering. The question is, quite simply, if this test finds something, what precisely will we do about it? And, considering my age and my current overall health status, is that something truly worth doing? That's it. That singular, potent question, when consciously asked before consenting to any screening or diagnostic procedure, forces the kind of thoughtful, individualized conversation that the inherently reactive medical system is not typically designed to initiate automatically. It compels both the patient and the physician to consciously contemplate the potential unfolding of the cascade effect before it has even begun. More importantly, it centers you, the patient, as the primary decision maker in your own healthcare journey, shifting the dynamic from passive recipient to active participant. Theodora lamented that she wished someone had imparted this crucial question to her 3 decades earlier, saving her from immense suffering and loss of independence. I am teaching it to you now, with the profound hope that it will empower you to make more informed choices. Let me now bring all these critical points together with the utmost clarity and unwavering confidence. There are 4 specific medical checkups that warrant extremely careful, thoughtful consideration and often a decision to decline, particularly after you have passed the age of 65. Firstly, routine full-body CT scans, which are almost guaranteed to uncover incidental findings that, while typically benign, will inevitably trigger extensive and often unnecessary cascades of further investigation for anomalies that were never destined to harm you. All the while, these repetitive scans deliver accumulating doses of radiation to an aging body whose cellular mechanisms repair that DNA damage with diminishing efficiency with every passing year. Secondly, routine bone density scanning after the age of 80, which frequently leads to the prescription of bisphosphonate medications that carry serious, well-documented risks, including atypical femur fractures and osteonecrosis of the jaw in very elderly patients. These risks often outweigh the benefits, especially when compared to robust fall prevention programs, which possess far stronger and more direct evidence for actually reducing the incidence of debilitating fractures. Thirdly, carotid artery ultrasound performed without any symptoms, where the surgery, carotid endarterectomy, that might be triggered by findings of narrowing can carry a stroke risk that is either equal to or, alarmingly, even exceeds the stroke risk of simply adopting a strategy of doing nothing invasive and optimizing medications for blood pressure and cholesterol instead. And perhaps the most critically important one, aggressive cardiac catheterization after a positive stress test in a patient who exhibits absolutely no cardiac symptoms. Here, landmark clinical trials have unequivocally shown that optimal medical therapy alone achieves precisely the same long-term outcomes in terms of preventing heart attack and death, but without exposing the patient to the significant procedural risks that can, ironically, cause exactly the adverse cardiac events you were attempting to prevent in the first place. It is absolutely crucial to state this clearly and unambiguously. None of this information implies that you should avoid your doctor or neglect routine medical care. On the contrary, genuinely beneficial preventive medicine is a cornerstone of good health and demonstrably saves lives. Effective blood pressure management, meticulous diabetes control, timely vaccinations, regular vision and hearing checks, and comprehensive annual medication reviews are all invaluable evidence-based practices that profoundly contribute to longevity and quality of life. What I am earnestly asking you to do is to approach those necessary appointments prepared, armed with knowledge and a specific, empowering question. Bring this question with you. Jot it down on a piece of paper if it helps you. Remember, the question is, if this test finds something, what precisely will we do about it? And considering my age and my current health status, is that something truly worth doing? Ask this question before agreeing to every single screening test, every single time. Your doctor will either have a thoughtful, evidence-based, and reassuring answer, in which case you can proceed with confidence and peace of mind, or they will struggle to provide a clear, convincing rationale. And that very lack of a definitive answer itself communicates something profoundly important about the utility of the proposed screening for you. Which of these 4 specific checkups surprised you the most or challenged your previous understanding? Please share your thoughts and reflections in the comments section below. I make it a point to read every single one. And if you or a loved one have personally experienced a medical cascade where an initial, seemingly routine test led to an unexpected and perhaps detrimental sequence of events, I encourage you to share that story in the comments as well. Your lived experience could genuinely help someone currently sitting in a waiting room, grappling with a similar decision, to make a more informed and ultimately better choice for their own health. Please share this invaluable video with someone you care deeply about, especially if they are over the age of 65 and have a tendency to attend every scheduled screening appointment without ever pausing to ask a single question. The most important action you might take for their health today could very well be empowering them with that one critical question that has the potential to change everything about their medical journey. Subscribe for more honest, evidence-based medical conversations that are designed to put you firmly in control of your own healthcare decisions. I am Dr. Abraham Khan, and you absolutely deserve to have the full, unfiltered picture, always. Disclaimer: please understand that everything shared in this video constitutes general medical information, meticulously derived from published research and established clinical guidelines. It is not and should not be construed as personal medical advice specifically tailored for your individual situation. Every person's unique health history, comorbidities, and risk factors are distinct, and some individuals may indeed possess specific medical reasons or complex health circumstances for which these particular screenings are, in fact, appropriate and beneficial for them, despite their age. Therefore, before initiating any changes to your scheduled medical care, it is absolutely essential and highly recommended that you engage in a thorough, open, and candid conversation with your own personal physician. This video serves as a critical starting point to empower you for that crucial conversation, but it is not and cannot be a replacement for personalized professional medical consultation.